Thank you, Mr. Chairman, and thanks to each of you for being here. One of the challenges, and my good friend from New Jersey and I go back and forth a lot on this dais, and clearly private equity in healthcare is an issue. There are things that are happening there that I have concerns about as well. One of the biggest challenges, though, as someone that has operated a small practice in rural America, and I think that any of the providers up here will tell you the same thing. The cost of doing business because of the regulatory burden is just absolutely through the roof. You couple that with decreasing payments from Medicare, Medicaid not keeping up, and then just the unbelievable battles that private practices face every day with third-party payers. It's a model that's not working, and it's driving people out of private practice. So, I hope that as we have a discussion about private practice, I hope that we will look not just at punitive measures that my friends on the other side of the aisle may look at from a private equity standpoint, but let's figure out the things that are driving people out of private practice. And it's the regulatory burden, it's the lack of payments, it's the, it's really, many times we feel like David going up against Goliath. The only problem is we don't have any rocks in our pocket to sling at them a lot of times. Dr. Starr, first to you, can you talk about how we're having this discussion about the physical exam? What's the link? I mean, what's the part of this where on remote home health that we've got a nurse or nurse practitioner, LPN coming in to do a piece of that? How does all of that fit with the payment model piece? Because we talk about telehealth, which in some cases in most cases it's actually a great added benefit. But how do you weave in the payment piece of this for the actual person, not the physician, but maybe the nurse that's coming out to the rural area to check on the patient? Do you see the dilemma we've got?
Yeah.
I think we're talking about either doing telehealth or in-office visit, but there's a very real component of someone, of a healthcare provider coming to the house. How does that fit?
Yeah, and currently I think that's one of the big holes that exists. The build amount for telehealth, has been mentioned, ideally can be lower because we don't have the overhead, unless that overhead exists because we need to have someone go into the home. And so for our hospital at home, all of that is rolled into the payment for hospital at home, and we do have providers, caregivers, whether it's community paramedics or nurses, in the home to do the physical assessment, and then we can do everything else virtually. So it is a model that can be really successful, but there is not a great answer yet to how to do that.
Do you think it would be? I think at some point you're going to have to segment out the various payment pieces. In offices, a certain amount, telehealth, a certain amount. Then you've got the expense. I mean, look, having somebody drive 50 miles or 100 miles from a central location out to do something, an injection in a rural community, I mean, that cost is exponentially more than the in-office visit. Yeah. So I think there's going to have to be some sort. I don't think bundling is the way to go because I don't think you gain the efficiencies. I think you're going to have to segment out those various costs.
Well, and that's where the regulations you mentioned really come into play. For example, currently with Medicare, to do a home infusion, a nurse has to start and stop the infusion.
Yeah. Let me get my time back here. Dr. Marotha, one thing that I'm going to disagree with you on is the fact that you think that telehealth in an office should be paid differently than an in-office visit. You've got an impressive resume, but you've never owned a solo practice in a rural area. I think there's a disconnect from what you see theoretically to what is in practice. That overhead still exists. That building still exists. Those You know, the staff still exists, the electric bill still exists. All of those things are there. I don't think that simply replacing, we're saying we're just going to go to telehealth and we're going to pay it less. I don't think that that's going to work, and I think it's going to exacerbate the problem of people being willing to go into private practice and practice in rural areas, or to my friends from New Jersey's comment, even in some underserved urban areas. So with that, I would just say I think you need to do a little bit of a reality check on what it costs to actually operate a practice in a rural area. And with that, Mr. Chairman, I yield back.